Irinotecan, brand name Camtosar, is a topoisomerase 1 inhibitor. It is also a chemtothecin analog. An easy way to remember the pronunciation of irinotecan is I, rhino, T, can, irinotecan. Irinotecan is mainly indicated for metastatic colorectal cancer. It is used either alone or in combination with other agents. It is sometimes used off-label for ovarian cancer and small cell lung cancer.
Before we go into more details about irinotecan, let's review some information about colon cancer that irinotecan is indicated for. Colon cancer is third most common malignancy worldwide. The risk factors for colon cancer are hereditary, inflammatory bowel disease, polyps, diet, which includes low fiber and high fat, and age, which the risk increases after 50 years. Incidence of cancer is higher in rectum, ascending colon, and sigmoid colon, but can occur at any part of colon. Even though colonoscopy is the gold standard for diagnosis of colon cancer, there are more and other tests that can be performed to diagnose colon cancer. Most common chemotherapy agents for colon cancer are fluorouracil with leucovorin, irinotecan, and oxaliplatin. One of the common anti-cancer regimens that includes irinotecan is FOLFIRI. FOLFIRI is indicated for colorectal cancer and includes folinic acid or leucovorin, fluorouracil, and irinotecan. It can be used as first line of therapy in a stage 4 of colon cancer, along with bevacizumab and with or without cetuximab.
Now let's talk about the mechanism of action of irinotecan. Irinotecan is a prodrug. It is hydrolyzed by carboxyl esterases in the liver to then become SN38. SN38 is a potent inhibitor of topoisomerase 1, and it is 1,000 times more potent than irinotecan. So why is the inhibition of topoisomerase 1 so important? Well, topoisomerase 1 relieves the torsional strain in the DNA strand. When SN38 reversibly binds to topoisomerase 1 DNA complex, it prevents relegation of the cleaved DNA strand. This results in accumulation of cleavable complexes and double-strand DNA breaks. Since mammalian cells cannot efficiently repair these breaks, cellular replication is stopped in the S phase of the cell cycle, ultimately leading to cell death.
Let's consider what happens as DNA unwinds during replication. As DNA unwinds, it acts like this rope when we pull apart its two strands. As you pull the strands apart, twisting tension builds up in the rest of the coiled portion. It is actually adding one twist to the remaining rope for each twist pulled out of it. At some point, you can't separate the strands anymore. The remaining rope is too tightly twisted. If you relax your tension on the rope, it will twist around itself in a supercoil. It is releasing tension. If you want to keep pulling the rope apart, you have to release the tension periodically, and one way to do this is to cut the rope and splice it back together. This problem has been best characterized in small circular DNAs. There are two methods of dealing with this problem in DNA. One cuts only one strand of the DNA double helix, and the other cuts both strands. Let's look at the first. Topoisomerase 1 enzymes cut a single strand of the double helix, pass the other strand through the cut, and reseal the break, relaxing the overwound molecule, which now has one fewer twist. Topoisomerase 2 enzymes do the same thing but with both strands of the double helix. Topoisomerase 2 cuts both strands of a double-stranded DNA and passes another double strand through the break and then reseals the break. So if a molecule of DNA is supercoiled, topoisomerase 2 can remove the supercoiling, 2 twists at a time, to yield a relaxed circle.
This is a short clip on how irinotecan works.
Characteristic adverse effects associated with irinotecan. Diarrhea, which is a black box warning, is seen in approximately 35% of patients who are on this drug. SN38, which is the active metabolite, undergoes glucuronidation. Patients with decreased UDP glucuronyl transferase, or UGT1A1 expression, are more likely to experience diarrhea. Patients over 65 years old are at greater risk for diarrhea. Dose reduction is recommended for patients over 70 years of age receiving every 3 weeks regimen. Another black box warning associated is myelosuppression, especially neutropenia. Other adverse effects are GI toxicity, vomiting, hypersensitivity, pulmonary toxicity, renal toxicity, and thromboembolism. In the next few slides, we will go over the mechanism of these adverse effects in regards to diarrhea.
In order to understand the mechanism in which adverse effects occur with irinotecan, you must first understand how the drug is metabolized. First, the prodrug gets metabolized by serum esterases and becomes SN38. SN38 is the more active form, and this is the part that actually slows the growth of the tumor. Now, step 3 is when SN38 gets glucuronidated and becomes inactive. Once it's inactive, it is eliminated in bile and feces. Toxicities associated with irinotecan are caused by high levels of SN38 in the bloodstream. Sometimes the inactive form, SN38 glucuronide, undergoes cleavage by bacterial beta-glucuronidase in the intestinal lumen. This reforms the active form SN38, which then leads to further toxicities like diarrhea and myelosuppression. Irinotecan exhibits linear pharmacokinetics. As mentioned earlier, it is converted to the active SN38 form by carboxyl esterases. The AUC of SN38 is only 4% of the AUC of irinotecan, but the drug is still effective because SN38 is 1,000 times more potent than irinotecan. The half-life of SN38 is 11.5 hours, and there is minimal CSF penetration with SN38. Irinotecan can be distributed to the sweat, saliva, and pleural fluid. It is metabolized by the liver, and that is very important for patients with genetic variations. An example is severe irinotecan toxicity has been observed in cancer patients with Gilbert syndrome, and this is due to the decreased glucuronidation of SN38, leading to toxic levels of the drug in the blood. And also, as mentioned before, Irinotecan is eliminated in the bile and the feces.
Many drug interactions can occur with irinotecan. CYP3A4 inhibitors such as azoles, clarithromycin, indinavir, lopinavir, cefazodone, as well as atorvastatin and steroids, when co-administered with irinotecan, will increase its concentration in the plasma. CYP3A4 inducers such as phenytoin, phenobarbital, carbamazepine, St. John's wort, rifampin, when co-administered with irinotecan, will decrease its concentration in the plasma. There are several mechanisms in which drug resistance can occur with irinotecan, including less enzymes to convert irinotecan to SN38, active drug efflux, reduced expression of topoisomerase 1, mutations or alterations in topoisomerase 1, change in cellular response to the camptothecin topoisomerase 1 DNA complex due to proteasome degradation or DNA repair, damaged DNA, and suppressed apoptosis leading to activation of transcription factor, nuclear factor, kappa B.
We hope you learned a lot from our video, and we thank you for taking the time to watch it.